So, good morning. I'm Dr. Macoro. Welcome to Interdisciplinary Collaborations and Communication Lines, key towards a palliative care holistic approach. This is a collaboration between Tondo Medical Center Department of Family and Community Medicine and the Mary Johnston Hospital Department of Family and Community Medicine Practice-Based Residency Training Program. So again, so this would be a lecture and a workshop. So the title of my lecture would be Challenging Patient Encounters. So for the basic counseling skills, how would you go about addressing patient encounters when the index patient or relatives are apprehensive? During these pandemic times, actually, this is a common scenario. Okay, this is a common problem among all of us. Okay, especially those who are in the clinics and in the hospitals. So, active listening skills in health education um, might be familiar to some of you, especially the CEA method. So, catharsis, education, and action method, no, as being defined, is a counseling technique that takes on many features of Carl Rogers' person-centered psychotherapy. So this method actually brings out the psychological concerns that result from wrong perception of reality and hinder appropriate behavior. So what are the two reasons why patients consult? For the medical students here, my students, actually, I have already discussed from time to time that there are two, and I think they are familiar with it. Of course, the symptoms, no, and anxiety associated with the symptom. So, the emotionally critical misperception actually caused the difficulty in absorbing education. Um, the emotional impact of illness then should be dealt with first. So what can we do again? So active listening skills are the skills wherein which can help us, okay, address these concerns. So we have to listen first, since every good conversation starts with good listening. So for the emotionally critical misperceptions, if you know Dr. Alan Janicio of UPPGH, I'm sure uh, the residents previously, like me, have been taught of this term number of years ago. Okay, so what is it again? It is the most anxiety-provoking, no, emotionally critical misperception. So the consultation usually um, lasts 10 to 15 minutes, no, for different patients to be seen. So you can identify it by identifying those with incongruence with reality as the physician perceives it, or if by correcting it, the patient is being allayed of the anxiety and being educated as well as comforted. Catharsis, education, action. So for the catharsis, it is actually the awareness of hidden emotion, giving it a name and coming to realization of what is behind it. There are actually 4 basic steps on how to address these emotionally critical misperceptions so that the patient can properly ventilate or uh, that's what we call as catharsis. Okay, so first, what came to your mind when you started feeling your symptoms? So in Tagalog, Ano ang naisip mo nung nakaramdam ka ng sakit? Second, what feelings came out when these thoughts came to your mind? So, ano ang naging damdamin mo nung naisip mo mga ito? Third, what consequence of your illness makes you feel this way the most? So, if the feeling is fear, the doctor can ask, ano ang tatakot mo nung mangyari dahil sa sakit mo, no? So, after that, you can summarize the emotionally critical misperceptions and the emotions associated with it. Okay? There are a lot of listening skills being needed. However, we can emphasize in this lecture workshop for perception checking, paraphrasing, reflecting back, and probing. So you should remember that you should articulate with the patient, no, by summarizing. Sa education part, for the education, we should remember that there are a lot of ways to execute education in CA method. So emotionally critical misperception, as we have already tackled, deserves priority attention. We should discuss pathophysiology and pharmacology if patient is no longer distracted by his emotions. Speak in the language of the patient must be appropriate for the educational attainment of the patient. So it doesn't only talk about talking in Tagalog or talking in English or talking in a dialect. You should also identify the culture from where he or she came from. Okay, the family he or she has been brought with, and maybe the exposures that he or she has been relating to. Okay, so scientific terms should be avoided except those which are necessary to the understanding of illness. The power of analogy should be used, especially if the patient can relate better for that analogy. So scientific evidence, anecdotes, testimony to convince the patient are at most the trending right now. Since every patient that comes in your clinic or in the hospital has already read beforehand, no? So they are there to confirm also what they have read or to clarify things which are actually sometimes sinister to them. So in essence, we should provide the assurance when needed, especially if the patient is already filled with guilt or fear of what has happened, especially if the laboratories are very bad or pag mas mataas yun sa normal, tapos alam nila na guilty sila sa mga kinain or sa mga di pag-inom ng gamot, yung mga gano'n na alam mo na dapat nilang ginawa at alam din nila na dapat nilang ginawa kaso hindi sila nakapag-comply. So, we should titrate to the right amount of anxiety. Kung yung isang pasyente naman pumunta sa consultation room, tapos assured siya na, sige, common siguro yung sabihin natin yung mga underweight or within normal, BMI, nag-consult, tapos yung lipid profile would be high, pero assured sila na there's false assurance sa sarili nila na, okay naman eh, kasi hindi naman ako malaki or, di ba, obese or overweight na magiging mas mag-predispose pa. Halimbawa dito sa nangyayari ngayon na COVID-19 or yung sa pandemic na we have to educate them also na this can happen even if you're not like this or not like that. So, Sorry. So, yun. Yun yung sigurong ma-identify ko ngayon na madaling tandaan na ititrate sa right amount of anxiety. So, for this, we have to propose an action plan to relieve the patient about the ailment or the distressing situation. Again, the appropriate time to explain the proposed treatment is after the emotionally critical misperceptions have been addressed. Okay? So patients must have ECMs about the treatment, use active listening skills again to elicit them, and emotionally critical misperceptions can be addressed immediately. So we have to remember that the longest way around is the shortest way home. So later we will have a workshop using the 4-question method of catharsis. And then the key scenario would be DL, a 20-year-old female consulted in your clinic due to breast mass. She has observed since 6 months ago. She has started to worry about it ever since her family attended the wake of her 48-year-old auntie, no? The youngest sister of her mom, who was discovered to have breast cancer stage 4 with metastases to the bone. She has been reading in the internet a lot about cancer and she's afraid she's gonna die soon. So you'd be dividing yourself into 5 to 6 members each per group. So using the core case scenarios above, expound other details to answer the following information, assigning the following roles to each. The index patient or the involved patient, the primary caregiver, decision maker, family medicine doctor or primary care doctor, and collaborating service doctor. So, communication and ethical issues in palliative care. So, communication, as we all know, is fundamental to good palliative care. The two-way activity requiring sensitivity, empathy, and active listening skills would be somewhat necessary in achieving accurate assessment of patients' physical, emotional, and psychosocial needs. Its essence is in how the physicians see and listen to the feelings and emotions of the patient and the family. So for effective communication improves, so how? How would the communication become effective, especially in the field or in the medical scenario? If, for example, you are in the clinics or in the wards or in the hospital, okay, hospital setting. So, since most of you here are students, I think, medical students or practicing doctors, accuracy, efficiency, and supportiveness usually happens during a good endorsement, okay? Wherein health outcomes are being improved and therefore satisfaction among the patients and the family of the patient is being provided. So therefore, a therapeutic relationship which is actually being highlighted as good through most of the time good patient care are being observed. Okay, so patient-led barriers. So we should remember that patients disclose as few as 40% of their concerns, and that those who are most anxious or most distressed disclose least. Okay, so communication and counseling skills in palliative care. Sometimes we're guilty that we only choose what we hear or what we listen into. So do you even hear the words I say, like this comic picture? So the other response is what? The ones I like. So attending behavior and listening. This encourages communication and shows the patient that they are being listened listen, and by showing empathy, the patients see that we understand what they are going through. In listening, we become aware of their concerns. Okay? So, attending behavior, seating arrangement. The ideal would be 45-degree angle. Head nods. You should do it somehow to tell or to show the patient that you are listening attentively to them. There should be an open posture so that the patient will be assured that you are not judging them or prejudging them. Okay? That you have an open mindset. There should be verbal voice of compassion. Eye contact can be done by actually checking here in the forehead. So since it's hard to actually do eye contact in a prolonged period of time, you can just check the in betweens of the forehead of the patient, making them feel that you are actually um, um, speaking to them eye to eye, when in fact you are not. So lean forward. So this also tells them that you are being attentive and that should be empathic and relaxed. So there'd be appropriate questioning. However, we should choose which appropriate ways to exercise in different situations. So open-ended questions and probes, close-ended questions, leading, paraphrase, clarifying, perception checking, reflecting feeling or reflecting experience of behavior, confrontation, focusing, summarizing. We can actually apply any of these in your workshop. So, specific communication issues. First, the breaking of bad news, especially now that it's pandemic, we use these from time to time, no? Not only to give the news that the patient has deteriorated, but first and foremost, when telling the patient if he or she is positive or negative, the apprehension or the anxiety from the patient's side is palpable, di ba? So, patients and relatives need time to absorb information and to adapt to bad news, especially if positive na yung isa, tapos symptomatic, di ba? So, correlating that with the palliative care approach, if you'll be discussing anything na related sa cancer or may consideration pa lang na cancer, apprehensive na yung patient at saka family. So, in your side, hindi ka din makapag-make sure na hindi nga siya malignant. Diba? So, you should break the bad news in such a way na seryoso siya, pero hopeful pa rin. Okay? Hindi mo pa rin sisirain yung hope from the family. So, advising patients and families with regard to prognosis is important. There should be a balance between informing patient about their illness and prognosis, as I have already told you a while ago. Even when bad news are imparted sensitively, we should remember that patients and families will still experience devastation, and the impact of the news can obliterate a great deal of communication. Kasi kahit na gaano ka kagaling na nagsabi na according dun sa feelings ng patient, natamaan mo yung nararamdaman nila, pero bad news pa rin sinabi mo, iba pa rin yung impact nun. So, we have to give them time. Okay? So, in so doing, kailangan natin alam yung spikes, no? Yung setting, perception, invitation, knowledge, empathy, and summary. So yun, we can further discuss this during the workshop or open forum. Okay, so goal of breaking bad news. Break the bad news in a way that facilitates acceptance and understanding and reduce the risk of destructive response. Handling difficult questions. Find out the patient's perceptions. If the patient does not wish to discuss such topic, then we cannot do confrontation, no? Leave it. They may not be ready yet. If they have other concerns, address it and answer it realistically. So, for the collusion, ano ba yung collusion? Di ba yung kasasabuatan na tinatawag? So, it occurs when relatives approach the healthcare provider to collude with them in constructing or maintaining conspiracy of either silence or falsehood concerning the seriousness of the patient's illness. So, collusion with the family is an abrogation of our responsibility to assist patients through the stages that might be needed to be for people to achieve calm and serene acceptance and dignified death. So, what can you do, no? So, focus the relatives' feelings, the reason for not wanting the breaking the bad news be done, their perception of the patient's understanding, and you should acknowledge the relatives' motives. Kasi first and foremost, I'm sure yung iba, may pinanggagalingan. Baka mamaya may nangyari previously na na-depress or yung pasyente, di ba? So, with this, assess the patient's understanding of their illness. So you should also investigate, no? And assure relatives that information will not be forced onto the patient if he does not wish to discuss it. The healthcare provider must think very carefully about what action on their part is in the best interests of the patient, or alternately, how the patient's confidence and trust in the relative and the healthcare provider might be compromised by unrequested and unexpected disclosure. So, in short, we should instead convince the patient's family that the patient has the right to know, no, and has the autonomy to express self-determination. Okay, so for dealing with anger, there are strategies that might help diffuse the anger. You should acknowledge the anger, invite them to explain the cause of the anger, listen to them in exploring the patient's feelings. No, the doctor must recognize also the feeling, acknowledge it, allow permission, understand, show empathy, assessment, and alteration through coping strategies. Don't be defensive. Instead, focus on the feelings and apologize if appropriate. You should clarify the situation so that legal matters can be avoided. Then you should negotiate a mutually acceptable solution. For denial, this is also common for a lot of case scenarios in medicine. So it occurs when patient maintains a positive outlook on their illness or prognosis in spite or despite of disclosure. So, yun yung tinatawag natin incongruence. For some time, ang tagal na diniscuss pa, ikot-ikot pa, ulit-ulit, may kita natin yan. Kasi yung patient, well, hindi naman natin masisi kasi kung hindi niya matanggap, lalong-lalo na, for example, ang scenario is breadwinner siya, tapos breadwinner siya ng family, nasa time na, nasa prime siya, prime of her or his life. So, ano siya successful siya, pero di naman siya ng isang chronic disease, no, na unfortunately, kaya na-refer nga sa palliative care kasi kailangan ng moral support and other supportive by psychosocial measures and symptom management if ever in the future na mapoprovide ng palliative care. So, isipin mo, hindi kaagad-agad, mahirap tanggapin ng isang patient na gano'n yung gaano mo man katagal na in-explain. Na kahit na siguro 3 months mo nang in-explain, babalik pa rin siya doon sa series ng DAPDA, yung ni Kubler-Ross, yung denial, anger, diba? Bargaining, depression, and eventually acceptance. So, sometimes nangyari siya, pero paikot-ikot, pabalik-balik. So, yun. Isa yun sa kailangan din. So, in summation, mapupunta siya sa denial pa rin, diba? So, inaalalayan natin yung family, pero kailangan pa rin nating pakinggan yung side ng pasyente. So it's a coping mechanism. It's a coping mechanism that promotes or that actually protects oneself against distress. Okay? So in handling patients in denial, identify if the denial is not absolute. If there's no evidence of awareness, leave the situation as it is, then reassess and follow up. So unrealistic expectations. Establish why patients believe the way they do by exploring their perceptions, whether they really believe it, challenge unrealistic beliefs, and look for windows of worries which may indicate that denial is not absolute, and establish also whether they are ill-informed. So, what about the communication between professionals, collaborative practice? So, it involves good communication. Professionals in hospital and community need to make channels of communication to acknowledge uncertainty and reach in a consensus with the patient rather than perceiving one discipline as being critical of another. So understanding of each other's roles by being aware of their own abilities and limitations and willing to enlist the skills of others help a lot. Yeah, it helps a lot. Okay, so trusting interpersonal relationships is also important. Okay, so the functions of communication actually with the public is that, of course, to inform the scope of the discipline, to raise the profile of the service, to assist the patient or the public in making choices, to encourage professional staff to consider palliative care as a career, and to be politically aware and to raise awareness of the subject and allow opportunities to meet and talk to politicians about the ways in which palliative care can be of benefit to a wide range of people. Like what has been discussed by the team Green in the Institute of Palliative Medicine, everybody has the business, or rather, palliative care is actually everybody's business. So, mechanisms of communication. Of course, be clear about the message. Consider those who will be affected by the message. Check the financial implications, the costs, the funds. You should prepare a question and, of course, an answer. Be aware of any related stories which might be asked. Decide who will be the leader. Relevant hard copy information should be made available. Yung mga pamphlets, paraphernalia. Yung mga ibibigay na information materials. Okay, so have internal meetings of external stakeholders to ensure that there are no surprises. After the event, there should be full debriefing held to work through any of the problems and improve the presentation the next time. So I think that's all for the lecture. It would be followed shortly by the workshop. Thank you.
Active listening skills. This is a case of Patricia Lim, a 26-year-old female, single, Filipino, Catholic, born on February 2, 1995 and works as a call center agent and is currently residing in Tondo, Manila. 1 week prior to consult, patient noted to have dizziness, rotatory lasting for 3 minutes, with associated signs and symptoms such as severe headache with pain scale of 7/10, chest pain, and pain in the back of the neck. No fever, difficulty breathing, cough, nausea, or vomiting. Patient self-medicated with paracetamol 500 mg tablet taken twice a day and afforded temporary relief. Few hours prior to consult, because of the persistence of the said symptoms, the patient decided to seek consult at our institution. Her past medical history is unremarkable. She has a family history of hypertension on both sides of her parents.
I'm Dr. Charmaine and your name is Patricia Lim, right? And what do you want me to call you?
Good morning, doctor. You can just call me Pat.
Okay, Ma'am Pat, what is the reason for your consultation?
Doc, I came here because I am experiencing dizziness. It started last week.
Okay, tell me more about your dizziness.
Every time I stand up after I woke up, it feels like the surrounding is spinning and it lasted for almost 3 minutes.
Mm-hmm.
And I just usually lay back down until it subsides.
Okay, it was stated here in your portfolio that you work as a call center agent, is that right? And how was your sleep?
Doc, I don't get enough sleep. I only sleep for about 3 to 4 hours a day.
Do you have any other diseases or do you take any medications or maintenance medications?
None, doctor.
Okay, so do you feel anything aside from dizziness? Because I noticed that you are constantly holding your head.
Doc, I am also experiencing a headache and I'm also having some chest pain.
Mm-hmm. And if you're going to rate your pain, pain from 1 to 10, 10 is being the highest pain and 1 is the being the lowest pain, how are you going to rate it?
Doc, for my headache, I think it's 7/10. And I took only paracetamol, but it only temporarily relieved the pain. And then for my chest pain, I think it's only 3/10, Doc. And I did not take any medications for that.
Okay, so Ma'am Pat, I'm going to do a complete physical examinations to identify what causes this. Okay, Ma'am Pat, all the findings during the physical examinations are normal. So, you mentioned earlier that you are experiencing dizziness, headache, and chest pain. So, among these 3 symptoms, which concerns you the most?
Doctor, actually it is the headache that I am most worried about because it affects my work and I am also afraid that I might have hypertension.
How did you say that you might have hypertension?
Doc, because both of my parents, they have hypertension and I'm just afraid that at this very early age, I might also have it.
I understand what you are feeling and don't worry, I'm here to help you. And I'm going to summarize first what we have talked about today, okay? So you came here complaining about dizziness, chest pain, and headache. So among all of these 3, the worrisome for you is the headache because it affects your work. Is that right, Miss Pat?
Yes, Doc, that is right.
Since all your physical examinations are normal, I guess that your headache is because of stress and of not having enough sleep. And so you have to understand your health is also very important. I'm going to give you some advice. First is your sleep. You should have at least 6 to 8 hours of sleep. And second, lessen the caffeine intake. Third, you should exercise regularly for like 30 minutes for 3 to 4 times a week. And lastly, you should avoid junk foods, preservative foods, and fried foods. You should have a balanced diet. You should have more increase intake in vegetables, fishes, and enough amount of meat. Do you understand, Ma'am Pat?
Yes, Doc, I understand.
Okay. So I'm happy to hear that. So I will be prescribing medications uh, for your headache, and you can take it every 8 hours. So first, before waking up, you should. Okay, Ma'am Pat, I'm happy to hear that, and I will be prescribing medication for your headache. And also, I advise you that after you wake up, try to sit down first for a few minutes before standing. And also, after, I suggest also that you should take your blood pressure at home regularly. And 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 if the symptoms you mentioned earlier keep persisting, I advise you to return here for another checkup. You understand everything I said, Ma'am Pat?
Yes, Doc, I understand. Thank you so much po.
Okay, I'm happy to help you. Thank
This is a case of Carlo, 46-year-old male, married, 5'7" in height, 78 kg in weight, Catholic and lives in Caloocan, works as a waiter and is a father of 3. He is a 20-pack year smoker, fond of drinking coffee and alcohol beverages. He also loves to eat oily foods in a heavy meal and sweets for dessert. For a month, he experienced intermittent chest pain and the feeling of food stuck in his throat. He had a teleconsult and the doctor requested some laboratory tests. After completing it, he opted for another online consult in which he was diagnosed with GERD. He looked up GERD on Google and found a lot of worrying information. This made him nervous and concerned about the rest of his family. Catharsis, education, and action.
Good morning, sir. I am your doctor, Sean Ventura. I am a family medicine doctor at Tondo Medical Center. May I know what is your name, sir?
Morning, Doc. My name is Carlo Reyes.
Okay, sir. I am here today to attend to your medical concerns. And may I know what your concerns today, sir? And rest assured that our conversation during this consultation will remain confidential. All your details will remain confidential, sir.
Doc, I am experiencing some chest pain and heartburn, and sometimes I feel that reflux while lying down at night. And I've had my consultation before, and they requested me some lab workups, and they found out that I have GERD. I was well advised by my doctor of what food and drink I should avoid.
Mm, okay, sir. What thoughts entered your mind when you found out about your condition?
Doc, honestly, I thought about my wife and kids, and I also thought, where can I get the money to pay for my medications?
How do you feel, sir? How do you feel about having GERD?
I was worried, Doc, because I have 3 kids, and based on my research on the internet, GERD could lead to cancer. And honestly, our resources are very limited, and I was worried about the possible hospital bills. I'm also afraid that I may have heart disease because of the chest pain I am currently experiencing.
Okay, sir. Could you describe your chest pain, sir, and how long does it occur?
Doc, it was like a burning sensation, and it usually lasts for about 5 to 7 minutes.
Okay, sir. Does it radiate, sir, to any body parts?
No, Doc.
Okay, sir. According to your description, it is highly likely that, yeah, you are having a GERD, but we are not totally disregarding a heart disease. And actually, heart disease could be prevented with lifestyle modification, proper diet, and being healthy as a person as a whole. So, uh, let's focus first on your grade, sir.
Okay, Doc.
Okay.
Thank you, Doc.
So, I will run down your worries. So first, you are worried about that your condition might get worse, right?
Yes,
Second,
Doc.
sir, you are also afraid you might have heart disease because of your chest pain. And lastly, you are worried about the expenses that you might be having, sir. Is that right?
Yes, Doc. And also, Doc, I am afraid that it may lead to throat cancer. I don't want to leave my kids behind at very young age, Doc.
Okay, sir, I really understand your concerns. And other than that, are you still having some thoughts or anything that you're worried about?
Yes, Doc. And I'm very scared of what will happen to me, too, Doc.
Okay, sir. So, I know and I understand your sentiments, sir. And I assure you that I will do my best to help you. However, I want to remind you that not everything you see and read on the internet is true. And I understand that you are worried about your kids, your family. However, don't worry that much because we, as your doctors, are here to help you and treat your condition so that it won't lead to any serious diseases, such as what you have said, like cancer or heart diseases. But in treating your condition, we really have to do yeah, lifestyle modification. You have to lose weight, sir, and you also have to avoid alcohol. And you've said that it was well mentioned by your doctor, so we have to we have to comply on that. And also, are you fond, sir, of eating heavy meals like that?
Yes, Doc. Yes, Doc.
So we really have to avoid that. Instead, I suggest to eat small but frequent meals. Okay. And also, I recommend refraining ingesting food 3 hours prior to bedtime.
Yes,
Okay,
Doc. No.
sir. And for your medication, we will just have to give you some antacid, which is the standard treatment for GERD. And so you have to be compliant on the treatment regimen, which I will be giving you later. I will send it to you. And also, please come back, sir. So being compliant will help you to resolve your condition. So after 1 month, you will have to go back to my clinic so that we could check if you're still having symptoms that you are worried about. Is that okay, sir?
Yes, Doc. Yes,
Do you still have any questions, sir?
and
And how are you feeling after our talk?
Doc, I felt relaxed and I am very thankful to you, Doc.
Okay, sir. I am really happy to help you, and I will see you in a month. Please follow up, and thank you, sir,